Hello and welcome to Eye Insider Ophthalmology Simplified. In today's class, we'll discuss about infantile esotropia. It is also called congenital or early onset esotropia. So this is a non-accommodative esotropia which has a large angle of convergent squint which occurs prior to 6 months of age in an otherwise healthy child. So the pathogenesis has been postulated by von Graffi due to some mechanical factors. Donder said it might be due to refractive errors, and Ciancia says it might be due to mechanical factors which leads to excess reflexogenic action. So this is the most commonly used theory. The features of this include cross fixation, which means when looking in the right eye appears normal and the other eye is abnormal, and when looking at the left eye appears normal and the right eye appears squint. So it has more than 40 prism diopters of deviation, that is we use a base out prism for esotropia. They can be manifest latent nystagmus, dissociated vertical deviation in inferior oblique overaction. So they can also be age appropriate hypermetropia. So we have to differentiate it from the sixth nerve palsy by patching one eye, the other eye has normal abduction. So the differential diagnosis includes Ciancia syndrome, Nystagmus blockade syndrome and sixth nerve palsy. Accommodative esotropias also. So Ciancia syndrome is a large angle esotropia along with nystagmus on abduction with head turned towards the adducting eye. So you can see there is nystagmus on abduction and the head turn is towards the adducting eye, which is also the fixing eye. And nystagmus blockade syndrome is a esotropia which occurs to dampen the nystagmus. So the null point is in adduction. Management of this is based on the congenital esotropia study. Please subscribe to my channel if you haven't till now. The criteria for early surgery is that the initial appearance of or the persistence of esotropia should be between 10 weeks to 6 months. Constant esotropia of 40 prism diopters or more, which should be there on 2 examinations 2 to 4 weeks apart, and the refractive error of less than or equal to 3 diopters spherical. So some say we should go for early surgery. Why? Because the success rate after 12 months of misalignment falls to 4% only, while others go for delayed surgery. Why? Because there is difficulty to measure the angle of squint, and there is difficulty to decide the dose of surgery which should be performed, and also the stability of deviation is also not known, and there is also anesthetic risk and operating risk in very small children, right? The surgery performed is bimedial recession. So the bimedial recession advantage is that it is easy because it is symmetrical performed. There is no loss of tissue, and even if there is overcorrection, there is possibility of readvancement in such cases. So if you like this, please subscribe to my